everyone. Welcome to Rehabilitation Sciences YouTube channel. And we are here with another very interesting lecture today, bladder function in multiple sclerosis. And we have with us Dr. Hina Garg. She'll be presenting on this topic. Dr. Hina, we would like to have your consent for making your lecture live on YouTube, ma'am.
Sure.
Thank you. Thank you so much for your consent. And the moderator today, Dr. Sagun Agrawal, he'll formally start the session. Dr. Sagun, you can start session, sir.
Thank you, Dharam sir. Good evening, everybody. Welcome to Rehabilitation Sciences. Today, I have got privilege to have Dr. Hina Garg with us. Dr. Hina Garg completed her bachelor's in physiotherapy from India and Master of Science from the Texas and the A&M University and PhD in Rehabilitation Sciences from the University of Utah. She is a neurological physical therapist and an associate professor in the physical therapy program at Rocky Mountain University of Health Professional. In 2019, she was recognized by the Academy of Neurologic Physical Therapy and Utah Valley Business Magazine as an upcoming business professional for establishing multiple sclerosis physical therapy program in Provo. She also serves on several local and national boards to promote the physical therapy. We welcome you, Dr. Hina, on Rehabilitation Science Group. Thank you for coming on our channel.
So I'll get started. Thank you for that introduction.
Yeah, ma'am. Thank you. Thank you, ma'am. You can start,
ma'am. Okay. Hello, everybody. My name is Hina Garg. I am a board-certified clinical specialist in neurological physical therapy. And today's topic is on bladder function in multiple sclerosis. This is a topic that's of unique dimension here. It's a topic of interest for me. I have been trained in India on pelvic therapy back in the day. And at that time, pelvic rehabilitation was up and coming and involved a lot of external work for a person being affected. I quickly realized that the profession has changed and the field has really expanded, where physical therapists are taking a huge role in managing pelvic conditions, not only in neurological conditions, but overall in pelvic rehabilitation. So over the last several years, I've been trying to train myself for more internal work, which is how pelvic rehabilitation therapists are being trained at this point. And I have had the fortunate experience being involved with my university to go through several educational courses, as well as do hands-on physical therapy practice because of the academic clinic that I'm attached with. So today's topic is bladder function in MS, because I also am the director of the multiple sclerosis and physical therapy program at my academic clinic. And that's where pelvic rehabilitation and my interest for multiple sclerosis comes together, really, where individuals with multiple sclerosis frequently complain of bladder dysfunction. And as a pelvic rehab therapist, I can see how physical therapy as a whole can help a person affected by bladder issues with the neurological condition, and the cause being the neurological condition or not. So this is kind of a unique area. Hopefully you enjoyed this presentation. I am in the gorgeous state of Utah. I am in Rocky Mountain University of Health Professions. And as the introduction said, I serve there as an associate professor. And I also work in the community rehabilitation clinic, where this clinic is established with Mountain Land, which is a local practice organization, and the Rocky Mountain University of Health Professions. It's a unique clinic, again, because we are able to serve individuals who are really in need of rehabilitation therapy and are not able to access it anywhere else. We provide all kinds of services, and I am the neurospecialist, and I also have added pelvic and vestibular services over there. This is something of interest, hopefully, to all of you as well. Me and my colleagues realized that over the last few years, we were creating content which was being utilized by people across the globe. So early this year, we were able to get together and launch a website where we're able to put the material that we create, answer questions for people, create blogs, and even include article reviews or evidence-based program related information. Please check out the website. You can register, you can sign in. It's free of cost. It's mostly educational, and hopefully you'll see a good comprehensive collection of information for physical therapy related topics. This is also good for some patient education. So please check it out, and I would love to hear how you like it. So let's get started with bladder function in multiple sclerosis. I mentioned to you that bladder related or urinary complaints are very frequent in people with multiple sclerosis. So before we jump into the topic of combining how a neurological condition can result in that complaint, we need to kind of refocus and learn a little bit about what a normal bladder anatomy looks like. Typically, the ureters, which are carrying filtered urine from the kidneys, join the base of the bladder. So if you can see my cursor, you see these ureters coming down, carrying the filtered urine from the kidney, joining that base. And that base where the ureters join is called the trigone. It forms a trigone area. What happens after is that the urine is stored within the bladder and then is excreted through the urethra. So what you don't see is a little pipe over here, and that's the urethra, which voids the urine or empties the urine out from the bladder. All of these pictures are from Big Picture Gross Anatomy textbook. So hopefully you can find these pictures in any anatomy textbook. I just wanted to kind of orient you for how the bladder sits within the pelvic girdle. So very quick, ureter carries the urine, and the bladder stores the urine, and the urethra excretes the urine. Now what you see is the bladder is below the abdominal cavity. It lies very low. It's in the pelvic cavity. See how it's right at the level of the pubis and within the pelvic girdle. So it really forms that component of that pelvic organ. There's 3 major pelvic organs that are lying within that pelvic cavity. And see how it's like towards the end, the bottom is that pelvic floor layer. So it's really resting on that pelvic floor layer. It's infraperitoneal. What that means is that it is within that pelvic cavity. So it's right below that abdominal cavity. It's between the pubis and the pelvic diaphragm. So what you see in that picture, again, if you can see my cursor, is this is the pubic symphysis. That's the pubic bone, the pubic arch, and see how you're continuing down. That's one of the pubic arches, superior pubic arch again, and that's your ilium, the iliac fossa. So see how the front of the bladder, which is called the apex, is lying right against the pubic bone. So that's resting right at the front. And as I said, the bottom is resting against the pelvic floor. So major orientation landmarks would be the apex. The base is where the trigone was. And again, that's important because of the anatomy or the structure of the bladder for how sensation is detected. So we'll talk about that later. And then the neck of the bladder is right over here where the urine finally comes through at the level of the internal urethral sphincter, follows through the urethra outside. Now the muscle of the bladder is the detrusor muscle. It's a smooth muscle, and it is involuntary, and the smooth muscle nature of the detrusor is what creates that contraction that is required to expel the urine through the urethra. So what happens is that it has multiple innervation from the autonomic nervous system, primarily parasympathetic nervous system, that creates that detrusor contraction or that excitation resulting in micturition or the voiding. And sympathetic relaxation just causes the filling. So at rest, what I'll tell you in next few slides is that generally parasympathetic system is not activated. It's a sympathetic nervous system that is letting the bladder to be relaxed, let the uterus bring the urine, and let the bladder fill. As the bladder fills, it expands upwards and sends sensations that require excretion. So again, innervation, maybe the next few slides a little bit more, but that detrusor muscle, the involuntary, the smooth nature, and that innervation is very important as we talk about MS, which is a neurological condition, and we'll see how it affects that innervation. The next concept is the internal urethral sphincter. The internal urethral sphincter is again a smooth muscle, circular opening right at the entrance of the urethra, and that is a primary structure that requires to be relaxed or contracted during filling phase or voiding phase. So just like the detrusor muscle, it has the autonomic nervous innervation, and typically it's like opposite of the detrusor. So if parasympathetic system is contracting, think about it logically, contracting the detrusor muscle, then the internal sphincter has to relax for the urine to pass. So it's exactly opposite, simply autonomic nervous system activation. It would mean that parasympathetic nervous system would relax the internal urethral sphincter, versus the sympathetic nervous system will contract that internal urethral sphincter, causing the filling. Now, again, I spend some time here because this is really important, as a neurological condition might affect these innervation patterns. The last one is the external urethral sphincter. So what you see is that external urethral sphincter is actually under voluntary control. It's called somatic control. It's supplied by the pudendal nerve. Again, just to kind of jog our memory a little bit, from the sacral plexus S2, 3, 4, the ventral rami come together to form the pudendal nerve, and that's supplying this external urethral sphincter. And that's where we are able to voluntarily control when we find a place to void. So such as finding the bathroom and then letting go of that muscle, of that external urethral sphincter, and then letting the urine out. So very key landmarks here, how it's resting within the pelvic girdle, and the detrusor muscle and its innervation, which is contrasting to the internal sphincter, the internal urethral muscle, as well as the external urethral sphincter, which is more under voluntary control when we decide we want to void completely. So this is a superior view, looking down from top, how the bladder is resting with respect to the other pelvic organs. So this is the pelvic cavity if you look down superiorly. So you see the pubic symphysis in the front, you start to see these pubic arches, that's your inguinal ligament. Towards the back, we don't see the sacrum, but that's exactly where the sacrum will be. And then you have your aorta dividing into the common iliac arteries, the external iliac going forward into our thigh. The internal iliac is the one that primarily supplies, but we won't spend a lot of time on the vascular supply. This is the one that supplies the pelvic cavity mostly. What I do want you to focus though here is how anterior or front, in front the bladder is, how close it is with respect to the pubic symphysis, and then right behind it. So we are looking at a female model over here, or a picture over here, and this is the fundus of the uterus. So right behind is a uterus, and then to the most posterior structure resting against the sacrum would be the rectum right here. So see the relationship, and everything does rest on that layer of pelvic floor. So what you don't see is the entirety of the pelvic floor. So in one of the next pictures, we'll see the entirety of the pelvic floor, but you see part of the pelvic floor. See how that's your pubococcygeus right in the front. The levator ani, major component of the pelvic diaphragm, attaches right over here, and then you have your iliococcygeus right over here. So everything is resting, the pelvic organs are resting on the top with this pelvic floor in the bottom. Okay, And you see how there's some fascial attachments. Again, those are kind of holding these pelvic organs with respect to the bones, being very important attachments for these organs to not move around as much. So again, just revisiting our anatomy a little bit, not spending a lot of time here. Now, this is that picture where we take away all the pelvic organs and primarily are looking at that pelvic diaphragm. It forms the floor of the pelvis, as you see. That's the opening of the pelvic girdle, or the opening, and that's the floor of the pelvis, and it houses all the pelvic organs, as we just discussed. It comprises of the levator ani. So when you look at the levator ani, it is primarily formed by three major muscles: the iliococcygeus, pubococcygeus, and puborectalis. So let's identify those really quickly over here. The one attaching to the pubic bone, going back, pubococcygeus. Iliococcygeus right over here, that's going and a little bit at an angle and attaching to the ilium. And then puborectalis just goes all the way back and it kind of circles around the rectum. So it's very hard to see when it's not circling around the rectum in this picture, but that's the one that's just going back, and it just goes around the rectum. And then you see other muscles that are present that kind of close the gap in that pelvic girdle, and those include your coccygeus. So this is your coccygeus muscle coming right from the coccyx laterally, and then we have our piriformis muscle, which again is mostly a deep gluteal muscle. So we see it from the back, but here it also forms that lateral posterior wall coming out from the sacrum, and then it exits, if we all remember, exits through the sciatic foramen, attaches to the femur, and causes that lateral rotation of the femur. So those are the muscles that we quickly identify: piriformis, coccygeus, pubococcygeus, puborectalis, and so that's your puborectalis, a little bit circling, pubococcygeus over here, and then your iliococcygeus over here. And what you also see is that it's pierced by several openings. So you of course are seeing the rectal, the anorectal hiatus. What we're not clearly seeing is the urethral opening in this picture, because this is again looking superiorly down. We'll probably see the urethral opening in that if you look at the lithotomy position, or legs open when the legs are propped into flexed positions and you're opening your legs looking down, up. So from down, up, you'll probably see the urethral opening. So we'll go over that picture really quick here just to identify the openings. And you see the general hiatus depending upon what's exiting, of course. So this is that position when you're looking from down, up, and you see the urethral opening, you see all the muscles. This is the urogeneral triangle, that's the anal triangle. Primarily, what you want to take away from this entire picture, or this entire slide, is that the muscles are really forming that big floor. Okay, they're going from front to the back. There's nothing else that's holding them, just those attachments, and a lot of fascial attachments, making sure that they're snug, tight, as well as holding the organs in place. So again, urethral opening, general hiatus, anal hiatus. And then what I also want to point out is the pelvic diaphragm, of course, has those levator ani muscles and the associate muscles like the coccygeus and piriformis. What you didn't see, the obturator internus, also very primary muscle, important for pelvic pain, I've seen in clinical practice. But let's hang on to the levator ani. There's also certain superficial peroneal muscles that contract in the same way, doing that pelvic floor, that Kegel contraction, as we all know. And those superficial muscles include ischiocavernosus, looking from down up, and then the transverse peroneal, superficial and deep, as well as bulbospongiosus in the center. And then we have the external urethral sphincter muscles. So those are all peroneal muscles. Let's keep that in mind as we move forward, because when we try to train these muscles as pelvic floor therapists, we have to know that they behave the same way as any other muscle in the body. So we need to be able to give them the right cues, verbally, manually, and then have them contract and relax with proper motor control when things need to go out or need to be held in. So I think just spending a little bit of the time on the anatomy helps us. This is another slide, very quickly kind of reorienting you how you may look at a male versus a female anatomy and how the relationships change. Looking at a sagittal view, this could be mid-sagittal right here. So that would be this way, right in the middle. So you have your pubis bone, you have your sacrum and coccyx, and you have your pelvic floor muscles attaching that way, forming a sling. See how this bladder opening, the uteral or the vaginal opening, and then the rectal opening. So that's another way to look at it. Just a very simplistic view. In the males, as you see, you know, I picked up these pictures so they look differently, but what you want to know is here is at the bladder. This we're looking in the front, that's the anterior, that's the posterior. Front bladder opening going out, the longer urethra in the males, surrounded by the prostate gland. And that's where people, you know, as they age, the prostate enlargement occurs, the urethral blockage occurs, and there's difficulty initiating urine. Rectal opening, no vaginal opening, of course. And that's a coronal view where you're looking at bladder and how it's suspended. See how it's suspended on that pelvic floor. Okay, so let's revisit our neural innervation as I kind of pointed out on that first or second slide. Talking about the neural innervation of the bladder is very interesting because a lot of it is involuntary, but then we have this external voluntary control for when we want to go to the bathroom or not. So that's why this is interesting, where we are either able to make that decision to go or not, or we are able to suppress that urge to go or not. And then what happens throughout that filtration process and storage process? What are the nerves that are being activated? So we'll identify what gets affected with people with MS, knowing how these nerves contribute to the physiology of micturition or voiding or excretion of that urine. So primarily, what you see in CAPS and bolded, those are the three major supplies, neural supplies of the bladder. Okay, so let's see how we can wrap our head around this. Sympathetic innervation is primarily via the sacral sympathetic trunk. So if you remember our anatomy, the aorta is coming down, the sympathetic trunks are coming right next to it. Those are the sympathetic chain and the ganglias. So they supply the skin, they supply the pelvic viscera and the perineum. So how that works is that they make contributions to the hypogastric plexuses. So the sympathetic trunk is just coming, that's the thoracolumbar outflow. So they're actually coming from way up because we're at the level of sacrum now. So they had nuclei at the level of thoracolumbar spinal cord, and they gave out the preganglionic neurons into the sympathetic chain, and they're all coming down and contributing to that hypogastric plexus. And that's how they supply the rectum, the bladder, and vagina. So that's how we remember that. Sympathetic contribution coming all the way down from thoracolumbar spinal cord to the level of the pelvic organs. Then parasympathetic innervation is a craniosacral outflow. So it actually has some neurons within the sacral cord, sacral level. So what's happening is that those nuclei are going to contribute directly from the sacral plexus. And it's very hard to see in this picture, of course, but you start to see the contributions from S2, 3, 4, all the way to those little tiny nerves coming out to these plexuses again. So both the sympathetic and parasympathetic pre-post ganglionic fibers are coming and synapsing within that hypogastric plexus or close to the organ. And depending upon which system we talk about, it's going to be pre-ganglionic, post-ganglionic, as we understand. So very simply put, S2 to S4 coming straight, contributing to the plexuses, again supplying the pelvic organs, rectum, bladder, and vagina. The last one is somatic innervation. Somatic innervation is the one that's also coming from the sacral plexus, S2, 3, 4, that contributes to that pudendal nerve. And that's the one that's supplying sensory in a sensory manner. The skin of the genitalia, the perineum, and the anus perineum is that outside view that we are looking in that open knees open legs position. So that's that entire perineal area. So everything sensory is being detected by the pudendal nerve at this level. And it's also supplying the motor. So that's the perineal muscles, the pelvic diaphragm, everything that we talked about in that previous picture, the pelvic floor muscles is being supplied by the pudendal nerve. So the way we remember this, and I'm not sure who designed this, is that S2, 3, 4, keep the feces off the floor. So it's funny because those are the muscles that you want to make sure that are contracting so that you're not voiding all the time, right? So you're not losing, you're not leaking any of these three important from the three important pelvic organs. So urine, vaginal, or your rectal contents are not falling on the floor. So those are the three major innervation. Talking about action is that sympathetic innervation, as we already pointed out, the bladder is being relaxed and the internal sphincter is being contracted. So if you think about it logically, it's responsible for filling. Parasympathetic innervation, the bladder is being contracted, internal sphincter is being relaxed. It's responsible for voiding. Somatic innervation is to that external urethral. So that external, which is hard to see here, but that external urethral sphincter, which is going to be our voluntary control. I want to go, I'm able to go, let's relax on the top of the toilet. So as you can see that the process is involving a lot of nerves working together towards this outcome of either the bladder storing the urine or voiding the urine. So talking about the physiology of voiding, and I'll keep it very quick. I know it's getting pretty extensive in terms of the anatomy. So the physiology of voiding is so interesting because there's too many controls if you think about it. We just talked about the autonomic nervous system. We talked about the voluntary control. Let's say that my bladder is full and I have to go, but I'm doing this presentation and I'm not able to right now. So I'm thinking in my brain, I'm controlling that urge. I cannot go stop, okay? But for people who are not having that voluntary control due to some or the other reason, they may not be able to suppress that urge. And that's when you start to see those problems. Or in itself, it's just giving strong urges. So that's where that physiology of voiding becomes very important. So let's just go over this really quickly. The bladder, that balloon structure that you see where my cursor is going to be getting the urine being filtered by the ureter, starting to store. And it starts to stretch the bladder muscle. Now those receptors, the A delta fibers, are the ones that are going to be responsible for sensing that stretch. And they send out information to the sacral level cord, the sacral centers. And that's a sensation that goes in. It either can result in a contraction and immediate voiding, or it can be suppressed. So the information goes to the sacral cord and is synapsed, as well as is sent upstairs to the brain, to the periaqueductal gray matter. So what happens is that information going up will have an influence by the voluntary control on the pontine micturition center, making that decision whether we go or not. So it kind of has a off switch at this point because the bladder is just filling, the information goes up over here via the red, and it's just not enough to really require voiding. And the brain kind of has that back and forth. It has an inhibition to the pontine micturition centers in the brainstem. And then there's inhibition all the way down. Bladder's just filling, no parasympathetic activation, and we are able to store the urine. So the first sensation that goes up needs that inhibition coming down so that we are not voiding with every filter drop. We need to be able to store the urine. So that's one loop, if you think about it. Let's say that you have filled the bladder quite a bit now, and there's a strong urge, really have to go. It goes up, again, goes through that interaction with the premotor, the motor cortex, right over there, the influences need to be taken care of between the planning of, do I have the bathroom close to me? I have the strong urge, but do I have that bathroom close to me or not? And depending upon that answer, you're probably, let's say the bathroom is not close to you, you still have that inhibition and that suppression on that pontine micturition center, still not able to go. Now let's say that we have that bathroom close to us, the sensation goes up, and we have those back and forth interactions over here with the motor cortex, and we're able to make that motor planning of whether we have the bathroom or not, and we decide that bathroom is close, and then we have that on switch. We activate the pontine micturition center coming down, and then now we're able to contract parasympathetically. The detrusor is now going to expel the urine, relaxing that internal sphincter, and we are able to void. So this is a very simplistic way to look at all these multiple level loops that have been defined as Bradley's loops for how the physiology of voiding works. So what we need to realize is that there is a local level of control as well as a central level of control. Now let's say that I'm not able to make any of these connections. I have a spinal cord injury, or I have these loss of voluntary control over here and at the level of the centers. So something's wrong with the central level of control for the physiology of voiding. So if you were to think about it, we don't have that inhibition coming down. Every time the stretch receptors sense that sense of stretch, send a signal, and that can be excitatory over here, resulting in activation of the parasympathetic neurons and parasympathetic contraction, basically at the level of the bladder, and you'll void. Okay, so a little bit of filtration can result in that activation of the parasympathetic pathway, and therefore that contraction of the bladder and relaxation of the internal urethral sphincter, and then therefore the void, which we probably don't want. Every time, which is an unconscious process of that filtration, we probably don't want to void with every little urge. And that's why that inhibitory pathway is very important, where we're able to store the urine. So if you think about that entire process in two phases, we're able to store the urine, and then when we're ready, we're able to empty the urine. Hopefully that's a little bit clear. Normal voiding is, if you also think about it this way, is a pressure system. We're trying to make sure that that bladder pressure does not exceed the urethral pressure when we're storing the urine. So the urethral pressure should be high. We're not leaking every time, or we're not voiding without our knowledge every time the little drop of urine is filtered within the bladder. If we want to void, we need to have the bladder pressure exceed the urethral pressure. Again, with that pressure gradient, we're able to void and excrete the urine. Now, how all of that makes sense for multiple sclerosis is the topic today. So as we know, multiple sclerosis is a progressive neurological autoimmune disease condition where the myelination of the central nervous system pathways are affected. So if you think about the normal pathway, we have the axon, we have the myelin, we have the conduction through the nodes of Ranvier, and those are the fast levels of conductions producing the effector response. In MS, again, very simplistic diagram, of course, there's this loss of myelination and we lose that conduction. Ultimately, what happens is that because of that exposure of that nerve, we may lose the axon itself. So the axon undergoes degeneration. And then we may start to lose the neuron itself just because of that degeneration process, which is long-standing at that point. So depending upon where the lesion location is, we may start to see several signs and symptoms, and they vary per person because of the nature of the condition, which is very variable. It begins generally with visual disturbances. Patients will present with tingling, numbness, weakness, fatigability. Again, that variable presentation, as you see in this next slide. Several symptoms that you may see in a person with MS, depending upon where that loss of myelination is and where that improper conduction is happening. What you see in red here in this slide is what's really important for the bladder proper bladder function in people with multiple sclerosis. So people with MS report at least 60%. These are older numbers. Now I feel in the next few slides, I have more current research from last 2-3 years, and more individuals are detected with bladder issues. What also you see is bowel problems. We won't talk about that in this presentation, and sexual problems. Again, I'm sure these numbers are higher at this point. But the other two things that you see is difficulty walking and moving arms. Now, remember, when we have to walk towards the toilet and then be able to safely sit down and then be able to use our arms to undress, all of those functions are also affected with MS. So sometimes you may see that the bladder problems are either exaggerated or just more complicated because of loss of arm and leg motions. So in multiple sclerosis, 90% of the individuals develop lower urinary tract dysfunction, and that's the lower urinary tracts would be the bladder and the urethra in less than 18 years of diagnosis. So as early as 18 years of diagnosis, several individuals with MS may start to develop some form of bladder issues. Over time, 80% of the people with MS may experience some form of bladder issue, and that could be from various symptoms of bladder dysfunction that we'll discuss in the next few slides. At least 1 in 10 have an onset of bladder issues with the diagnosis of MS. Now, common complaints with bladder dysfunction, as you can now imagine, the two phases of storage of urine or voiding of urine. So they could probably have issues at both levels. So let's see how. They can complain of urinary urgency, so strong urges being present, urinary frequency, frequent urges being present, nocturia, which is more nighttime voiding, and urge incontinence, so some form of leakage preceded by a strong urge. That's during the storage phase. In voiding phase, when you have to actually let go, you're sitting on the toilet, there may be hesitation or slowness of the stream. And then there may be, because of that incoordination, as we'll discuss in the next few slides, some urinary retention. They're not able to completely void, and even include some overflow incontinence. And we'll define these terms in the next few slides. Just to highlight the extent of the issue in people with MS, bladder and bowel dysfunction is typically insufficiently diagnosed and treated. 53% of the people with MS will have some form of detrusor overactivity if they're complaining of bladder issues. 43% of the people reported some form of detrusor and sphincter dyssynergia. So when we talked about, okay, what needs to happen at the level of the bladder, and then at the level of the neck of the bladder, which is that internal sphincter, and the external sphincter, which is that external peroneal muscle, as we talked about. So all of that needs to happen together. It's a very coordinated, concentrated effort to have that urine expel out. But with the neural condition and the neural pathways being affected, the coordination between the two different nervous systems is affected. And that's where you may see some incoordination of the detrusor contracting and the sphincter relaxing, resulting in poor urine excretion or retention, as you would think about that. And then 12% of the individuals will also have some areflexic or atonic bladder, just because they don't have that detrusor activation anymore. So it's a pretty significant problem in individuals and can result in quality of life issues. What's also known is that several kinds of location of those lesions, as we said, lesions can happen all over the brain and spinal cord, can result in different kinds of complaints and presentations of urinary dysfunction in MS. So those are some things that I've listed over here. Again, current research. Higher brain lesions have shown to be associated with greater levels of complaints of incontinence, and multifocal or diffuse types of lesions can result in that variable urinary tract dysfunction presentation in our patients. Now, incontinence is any involuntary leakage of the urine. That's the definition for urinary incontinence. Any involuntary leakage of feces, if you think about the bowel contents, would be defined as fecal incontinence. So today's lecture is mostly on urinary dysfunctions. We'll talk about urinary incontinence, but these terms may apply to fecal incontinence as well. So the major types of leakage that you may see, or causes of leakage that you may see in people with MS, could be stress related. Anytime there's a stressful activity that raises the intra-abdominal pressure. So this is that pressure theory that we were talking about. So let's look at that diagram really quick so that we understand what we're talking about. So we said the bladder pressure should be in concerted efforts with the urethral pressure, depending upon whether you're trying to store the urine or void the urine. What also needs to be in our minds is that right above our bladder is the entire abdominal cavity. So anytime we force, anytime we strain, anytime there's an increase in intra-abdominal pressure, like coughing or sneezing or exerting, lifting something heavy, we are pressing down on that bladder. So what happens is that if the pelvic floor muscles, the urethral pressure is not high enough, with that intra-abdominal pressure, we may start to see that leakage in the urine. So that's a stress-related incontinence, where an increase in intra-abdominal pressure with weak pelvic floors, we're not able to control and leak. Urge incontinence, we had that term come up earlier, where a strong urge is present at the level of the bladder, and it just results in, so basically the leakage of urine is preceded with the strong urge in our patients with MS. So again, this is commonly seen in our patients only because of that sensory neural control being affected. So they may start to feel some strong urges early on when really the bladder is not that full, because generally, if you think about when we have to void, the bladder is at least 400 ml is when we get that urge to void. But these individuals may start to see an urge at 100 ml or less, or even like 200 ml or something lesser than that normal typical urge requiring to void. So these individuals may start to see some leakage of urine preceded by a strong urge, which really is not related or really is abnormal if you think about it. The third kind that you see is overflow incontinence. So this is when there's some form of blockage, and that could be the person not able to coordinately release that internal sphincter. So you're just, the bladder is full and you're not able to release, and then you just start to dribble. So that's what overflow incontinence is, chronic leaking or dribbling. That could be either following you using the restrooms, following micturition. That's only because it was incomplete emptying, and now you still have something and you're just dribbling. So that's how it's called, overflow incontinence. You're full and you're dribbling. Functional incontinence is typically described as leakage when you have a problem related to any physical or mental limitation in using the restroom. So you're trying to rush to the restroom, your leg is not coordinating, and your hands are not coordinating to go through that act of micturition, and that's resulting in an ultimate leakage of urine. So that's how functional incontinence would be described. All right, so what happens in MS now, knowing what we all know about the bladder anatomy and the bladder innervation, is that in MS, you can see issues because it's a neurological condition affecting the brain and spinal cord. You can probably see how it can affect at any level on that neural innervation. So now let's say that we get that stretch sensation and our information going up is affected because of MS, because of spinal cord lesions, or because of lesions here at that level of brainstem, or even like higher. We're not able to control with our voluntary influences, our motor influences and motor planning influences, and we lose that inhibition coming down, and therefore we're just getting an urge and we're voiding, getting an urge and we're voiding. That's that leakage that you may see. Or we are just probably seeing some lesions at the level of the spinal cord and maybe the cerebral cortex again, and we are just not able to coordinate it well with the sphincter relaxation. So you may start to see increased urge, increased pressure sensation, or you may start to see that improper tone in the sphincter whenever you need to void. So either our detrusor is just getting crazy, or it's that sphincter not relaxing when it needs to be. So those are the kinds of issues that you may see in people with MS. So either increased sensation or that dyssynergia of the detrusor and the sphincter actually carrying out that process of voiding. Another type that you may see in people with MS, if you have lesions right at the level of the sacral cord, is flaccid bladder. So basically, you're not able to produce any parasympathetic output only because it's the sensation is affected at the level of the sacral. That's where that primary pathway is. So how do you manage such a condition? There's several things that have been researched and found or are recommended in people with MS. Of course, as we know now, depending upon the presentation, the type of the bladder, is it adaflexic or reflexic type of bladder? What is the functional level of the individual, as well as what is the individual's preference and physician's bias? We have different kinds of management that you may see for bladder dysfunction in people. What you might want to do is have a beginning with the urodynamic evaluation, and that's what urologists typically run an entire profile, figure out what the issue is. Is it the bladder? Is it the pelvic floor muscles? Is it just that dyssynergia that we see between the sphincter and the bladder muscle? If it is detrusor hyperactivity, is it, if that's the detrusor sensation that's being, that increased pressure sensation that we're getting, then you have medications, and then pelvic floor muscle training. And that's what I was suggesting early on, that something of interest, I didn't realize that we could make such a big difference. Pelvic floor muscle training is well recognized as an intervention for helping in urge as well as in stress, as well as other forms of incontinence. Botox, many of my patients have taken Botox for that bladder so that you don't get that strong urge every time. Cannabis has been used for controlling those sensations. Catheterization, so manually evacuating your bladder. And then some form of neuromodulation. Again, it's that sensation. So can you modulate the nervous sensation so that you have an effective storage or control of that bladder? And then reconstructive surgery, depending upon what the issue is. So primarily what I have seen is anticholinergics or medications that will help with that sensation, combined with pelvic floor muscle training or Botox. And then I've seen individuals with catheterization. When these conservative treatments probably fail is when you go for higher level or secondary or tertiary treatments. Now, if you start to see that dyssynergia, that voiding dysfunction, when you have to go, you're not able to relax the sphincter, let the bladder contract and go, then there's medications, of course, that can release that internal sphincter. Again, baclofen, alpha blockers, baclofen, Botox, all of those are very useful because of that coordinated effort. And then some training on intermittent catheterization and the technique, and you have to consider the hand function and cognition, when the person can actually insert the catheter and within the urethra and evacuate the contents or not. If they're not able to do that, then you might consider indwelling catheters. And that's when you let the catheter be in and have a little bag externally that you can drain. So the urine keeps draining into that bag, and you can drain it when you're prepared to drain it. Where does pelvic floor rehabilitation come in? Pelvic floor muscle assessment and training, as pelvic therapists continuously do, they figure out what is the issue. In addition to that urodynamic evaluation, I've seen that sometimes the patient does not share this information with the doctor, and they just see a pelvic therapist, or vice versa. Sometimes they don't even share it with the pelvic floor therapist, not realizing that they can do something beyond the medications. So it's a treatment that has been recommended in people with MS, where you're learning about bladder management. Can you help with the detrusor hyperactivity? Can you help with the weak muscles, relaxation of the muscles or not? There's several compensatory techniques that people with MS can utilize when they learn and work with the pelvic floor therapist, how to manually facilitate the bladder to void. It could be suprapubic tapping, right positioning, relaxing the muscles when they're needed, or that coordinated effort, creating that coordinated effort. And then when to use straining to release the urine, and then appropriate fluid intake. So all of that is part of that pelvic rehabilitation in people with MS. And you can see effects during the storage phase, helping with that storage phase, as well as that coordinated voiding phase, or that evacuating phase. All right, there's a lot of evidence about pelvic floor muscle training in people with MS. I put up the most recent ones that I could find. a randomized control trial for 12 weeks of supervised versus unsupervised pelvic floor muscle training in people with MS showed that both groups improved effectively. Only the group that was supervised, so that's when as I told you earlier, pelvic rehabilitation therapists have manual cues. You do internal work to stimulate the bladder or stimulate or suppress the bladder, or train the muscles so that for that storage as well as coordinated excretion effect. So basically, people who had that supervised, that manual work with the therapist improved better in quality of life and urinary incontinence severity, as well as other lower urinary tract symptoms. And then other studies showing some form of pelvic therapy versus a sham or nothing have shown that they decrease individuals with MS who got pelvic floor therapy improved on storage of urine and voiding symptoms and quality of life. And in a systematic review, and this is the one that I would highly recommend that you read, there's a systematic review that combines 6 randomized control trials, lots of patients, of course, in that combined review. Overall, individuals with MS, as compared to no treatment, showed a decrease in incontinence episodes, improved quality of life, and decreased severity of that irritative urge type symptoms, and then decreased nighttime urination as well. So hopefully this presentation has given you that little bit of that anatomy of how bladder is oriented, the relationship with the pelvic girdle, with the abdominal cavity, as well as the pelvic floor diaphragm. And then kind of took you through the innervation and why that's important in people with MS, as well as various dysfunctions that may happen in people with MS in terms of that physiology of voiding. When do you have to go? How do you control that voiding process or not? And there's some interesting findings with medications with pelvic floor therapy. Does that make a difference or not? So hopefully some evidence helps you in understanding the role of pelvic rehabilitation in people with MS. So at this point, I'll stop, and I thank you for attending. These are all the references, and open for discussion or questions.
A very good evening, Dr. Hina, and thank you for the presentation. I think it was very elaborate and encompassed almost all aspects of dysfunctions, what can happen in neurological patients, including multiple sclerosis. And in multiple sclerosis, it is one of the silent symptoms that many patients suffer just because they don't open up to the therapist or to the physician, and complemented by motor problems and problems of fatigue and sensation, they are almost compounded. And a lot of time, females generally do not open up about these problems to the therapists. And many therapy setups I have seen are do not have a space for managing such problems also. Yes, Dr. Hina, the problem in detrusor is a smooth muscle that is being hyperactive or hyperreflexic. And we as therapists are training pelvic floor, which is a voluntary muscle. So how do you say that by exercising the voluntary muscle, I can improve something that is involuntary or smooth?
Yeah, that's a great question. No, so in the loops that I showed you, of course, those were simplistic, and it's not like I cannot elaborate on all of this information in of course, less than an hour. But there is some correlation between the pelvic floor contraction and inhibition pathways. So that's where you try to activate the right pathways for training the bladder.
Right.
But you have to kind of go through that assessment with the pelvic rehabilitation therapist to realize what is it. Because I've seen both issues happening. You can't, like I've seen patients who are doing pelvic floor contractions and they're still leaking. So you have to see why. What is affected in that pathway.
Right. And is there any complaint that you see in history or on examination that you recommend a patient for Botox and or for neuromodulation?
Well, so it's tough because generally pelvic rehabilitation is an afterthought sometimes. So patients are already either taking some Botox. Neuromodulation really is a tertiary treatment, so it's like way towards the end. Like if everything has failed, type of treatment, that's when neuromodulation, like it's a surgical intervention or something like that, more like a nerve training is thought of. Initially, people are maybe considered for medications, and I think I'll have to say honestly, that medications are outside of our scope of practice, and medications are very effective for these conditions. So I wouldn't say that replaces your pelvic floor rehabilitation replaces medications. I would never say that. Medications are the prime treatment. But then the people that I see they're still on medications, and they're still incontinent. They're still having all these problems of lower urinary tract symptoms. So that's when pelvic rehabilitation does make a difference, is what I've seen.
Right. So thank you, Dr. Hina, for sharing this wonderful piece of knowledge and your experiences in patients with MS and bladder problems. Thank you.
Thank you.